Over to you, sir.
Dr. Shiva, great privilege to be in this session. Just 1 second, let me. Yeah, you're able to see the slides, right? Yeah, I must thank Dr. Gujral and Dr. Shubha and the team for doing this. And this is an excellent forum, I'm sure, where the pathologists and other hematology aspirants are regularly attending this meeting. I had done a similar lecture last year, and then I modified it a bit, and I would prefer that if there is any ongoing queries or comments, please do it side by side rather than waiting for the entire lecture to be over. So as we talk about like meaning, the philia means love, and then we have neutrophilia, basophilia, eosinophilia, hemophilia, and thrombophilia. Not necessarily it is in love with it, but it was one is of for plenty we talk about philia, and the other one is that probably more attracted towards blood flowing and clot forming. So in terms of thrombophilia definition, I've taken this a few slides from the ASH approach to thrombophilias, and we all know that it could be all hypercoagulable states may have a thrombophilia, but all thrombophilia are hypercoagulable states, but all hypercoagulable states may not have thrombophilia. Essentially, we use the word thrombophilia when there is a heritable condition, not otherwise. We understand the Virchow's triad of stasis, injury, and a coagulable state there. Just to discuss and give some thought provocation along the way, let's visit this 56-year-old man who was evaluated for his hypertension in the ICU. He was admitted about 3 hours ago with acute onset of dyspnea. CT angiogram in admission showed a large central pulmonary embolism. Treatment was started and he was started to ICU. He was transferred to ICU, and an hour later he becomes hypotensive. Physical examination showed tachycardia and low blood pressure, and saturation is low even on oxygen. Clear on auscultation and cardiac examination revealed a systolic murmur, which usually can happen in a patient with thrombophilia or acute pulmonary embolism. Which is the most appropriate treatment at this point? Can somebody type in the chat box, please? Shiva can answer. I am not able to access the answers there. So if Subha has the answers, please.
Sir, people are just starting to type. I've not got any response yet.
Okay, no problem. The answer is adding a recombinant tissue plasminogen activator at this point would be the best option, because you need to thrombolyze this clot which is sitting at the bifurcation, and because of which the cardiac output is poor. And estimated prevalence to venous thromboembolism or pulmonary embolism is about 1 in 1,000. In other words, any walk-in patient or anybody walking on the road, there is a 0.1% chance that that patient can have thrombosis in the leg or in pulmonary embolism. You go to a marriage party, 1,000 people there, one of them may have thrombus. The precise number is not clear in India, but however, we can make an extrapolation from what is there in the US, and we are about 5 times the population of US. So that's the number which we can think of. And if you say that breast cancer and AIDS are very common in the country, even both put together cannot match even half of what new cases of PE is year per year. So you do understand the gravity of the problem and the importance of knowing the diagnosis and how to do that in India. So by chance, if you take that extrapolation of the numbers, we will get about 2 crores patients in the country managed by just a handful of pathologists and clinical hematologists to manage them. Of course, all the specialties manage them. And if they get about 10 to 30% chance that they will die within the first 1 month of diagnosis. And sudden death is the first symptom in 1/4 of the patients. And among the patients who have one half will have long-term complications, and they may, and about 30% of them may have a recurrence of it. So this is the problem which we need to address. Many of them can have post-fibrotic syndrome, and about 1/3 of them can have recurrence in the next 10 years. Anybody who has a thrombus can have about 5 to 10% of thrombophilia, and that's the point of discussion today. How often, in how many we should test for thrombophilia. Even if you test about 10% only, we'll get it. Now, when you have a VTE, you understand that the risks are plenty, and one of them happens to be thrombophilia. Let's focus there, but at the fringe of it, we should be able to understand what are the other risk factors and to understand that better. Of course, this is which is more common in men than in women. The estrogen seems to protect the women over the men. If you are not anticoagulated adequately, the chances of recurrence, a lifetime recurrence is about 50%. First 1 year itself is about 30%. And therefore, it becomes imperative to find out this diagnosis and treat them because of that problem. We must understand that pulmonary embolism can occur even without a deep vein thrombosis. Therefore, a spontaneous pulmonary embolism is possible. Often we fall back on certain criteria to make a diagnosis. So I mean, you don't have to remember these, but at least understand that there are some criteria to predict somebody to have a DVT if you have a clinical suspicion. So you have classically a patient of unilateral leg swelling with no fever and redness, maybe some calf tenderness, and there may be some superficial veins seen. And these are the situations when you consider a vein thrombosis. Pulmonary embolism, we are looking at other signs in terms of tachycardia. The patient has where the patient may have hypotension, hypoxia, and if there is a DVT, etc. So these are derived based upon multivariable analysis after considering all the potential confounders and the potential causes, and then following up the patients and seeing how many of them had thrombosis. Could be coming from case control studies or cohort studies. All of them put together, multivariable analysis is done, and the weightage is done accordingly. All we need to know is that what is the risk stratification of probability of having DVT. When it comes to diagnosing probability, please understand that it is important to know the pre-test probability. Accuracy of the test would give you the post-test probability. The pre-test probability, as we mentioned, is about 0.1 to 0.2% of the walk-in population may have thrombosis. Multiplied by the ability of the test to diagnose would give you the post-test probability. All by doing the risk stratification or the Wells criteria is to improve the pre-test probability by adding certain numbers from the population who had to. We are saying there is a 17% chance that he may have a thrombus, and therefore we do a particular test. Now, any patient of thrombosis, we would have to ask various questions. What's first question is diagnosis of thrombus. Is it in the leg or in the lung? If we have to start the anticoagulation, how do you weigh it against the bleeding risk? How do you monitor them while on treatment? How long would you use? And if they have any other risk factor, how do you intervene at that point? So we have various scores for this. Lower limb DVT, Wells score, upper limb DVT, constant score, pulmonary embolism, Wells and Geneva. So the Wells, there are two types of Wells. Whether to start on anticoagulation, we have Corona score for cancer, medical Padua and improve, surgical Caprini. All of them would have resorted to a predictive probability based on this multivariable analysis where the odds ratios were looked at based on factors. As a particular weightage has been assigned, and that becomes the score which we add on. Then comes how long to use, in other words, when to stop. A lot of situations there is indefinite therapy is required. In certain situations, only short term is required. However, when it comes in between, there are certain criteria which we can include to decide when to stop it. Just to show you how it looks, you don't have to memorize any of these. It is available in the mobile phones. We should be able to access it from MDCal or any other softwares, plug in the numbers, get the risk stratification, and then decide whether to test further or to anticoagulate them. When there is clinical equipoise, people do randomized control studies. Randomized control studies per se is not enough. Now, we have to do systematic review and meta-analysis. So there are various questions now. As the corpus of scientific literature increases, our burden to understand these also increase, and therefore we must understand to know how to evaluate systematic review and meta-analysis. I wouldn't go into the details of it, but however, just to give you a flavor of controversies associated with pulmonary embolism and VT and the thrombophilia. When you analyze a study, you balance it out between two things. One, how often the disease is coming back, what is the recurrence rate, what is the mortality associated with the problem, and what are the risks of bleeding. So we are always balancing the advantages versus the risk of bleeding. By and large, any anticoagulation causes about 2 to 2.5 or 3% chances of major bleeding, as against of 2% anticoag. So that's the bottom line, generally what weighs over. The good versus bad, the good oversees the bad, and the disadvantages are overcome by the advantage we can get by 10-20%. Now, the first question is, what's the best diagnostic algorithm? In a suspected patient, we talked about well scoring and deciding between D-dimer and CTPA. For us, essentially, we go by a DVT to be checked by Doppler, a D-dimer to be checked by blood, and a CTPA. Now, CTPA has cost incurred, the time incurred, and the inconvenience incurred with CTPA. That's about 5,000 to 7,000 rupees for the CT scan and everything put together, maybe about 7,000 to 8,000 rupees. Doppler ultrasound is cheaper, but labor intensive, and compression ultrasonography can be done in patients. D-dimer is the next option, the blood. So ease of testing D-dimer versus ultrasound versus CTPA. Therefore, in a high probability well score for a pulmonary embolism, CTPA is the diagnosis of choice. Don't waste your time with D-dimer, bottom line. Whereas it's a low risk or an intermediate risk, start with D-dimer. If it is high, then proceed with CTPA. If there is a DVT suspected, if the well score is intermediate or high risk, go for ultrasound. If it is not low risk, go for D-dimer. Negative predictive value of D-dimer is 100% almost. Now, That is where the low or intermediate pretest probability, if it is positive, then if the D dimer is positive, do a CTPA. But direct do if it is positive anticoagulate, it is negative, observe. So that's the levels at which we're looking at D dimer, CTPA, anticoagulation. Now, around the thrombophilia, we can ask multiple questions in various directions. We stick to adult patients with venous thromboembolism and a few touch points on arterial thrombosis later. If there is a VTE, first question we are asking is it DVT or it is pulmonary embolism? Next question we are asking is essentially, is it acute or is it chronic? That means it is recurrent. Let's assume for a moment that all we are discussing is with acute for now. If it is acute, the next question you have is it provoked or unprovoked? If it is provoked, means there is an obvious visible risk factor you can identify. Not it happened because you have caused trauma to the wall. In triad or virtuous triad, we're looking at the stasis, we're looking at hypercoagulable state, and we are looking at injury. Essentially, provoked means there is an injury happening, either by cancer, either by surgery, either by immobilization, either by air travel, etc. That is provoked. There is an injury there. In the absence of injury, and it is a hypercoagulable state, and you are now saying it is a provoked, unprovoked, that means essentially we are assuming a thrombophilia situation in the mind. Let's take the same patient in context. He has come in with the acute onset of hypotension in the ICU. CTPA has been done because he was a high risk with a PE with hypotension. He was started with this, and this gentleman is now falling into an unprovoked thrombosis. So provoked or unprovoked, that's a question again in our mind. Now let's take this unprovoked and provoked separately. Let's for a moment think that he has provoked situation. If it is provoked, we are now looking at, is it a transient or it is persistent? Because this will decide your duration of therapy. If transient period, you would need to give less than 3 months or max 6 months. If it is persistent, we have a high probability of recurrence, and therefore one may have to continue it throughout the period of the risk factor being there. Whereas it is unprovoked, the question is now coming when to stop or when to start checking for thrombophilia. In a given scenario, the current thinking is that whether it is unprovoked or provoked, and if it is unprovoked especially, if there is pulmonary embolism, you need to give it indefinite, which is lifelong. Definitions of indefinite are 2 years, 5 years. The world is not able to get onto the topic of that. But however, we need to discuss with the family because there is equipoise there and it is a shared decision making how long after 2 to 5 years. However, let us assume that it is for lifelong. For lifelong, would you need to do a thrombophilia testing is the question which everybody is asking. From the point of view of therapeutic intervention, doing a deficiency which causing thrombosis or a mutation with gain of function, neither of it is going to affect the long-term decision making of continuous stopping. However, when it comes to the point of stopping, say after 2 to 5 years of unprovoked pulmonary embolism, he's okay, doing fine. The patient says, I want to stop it. As per the guideline, we say you must continue. And we say that, okay, if you get a thrombosis, thrombophilia testing positive, then are you willing to continue long term? Knowing well that only about 30 to 50% of the patients may be able to get a thrombophilia diagnosis accurately. So what should be our approach? Patient has come to you with thrombus. You take the history to look for provoked causes. First, that is infection, pregnancy, immobility, etc. Now you go into an unprovoked history taking here. We look at thrombosis, we look at history of MPN, look at IBD, nephrotic syndrome, obstetric history, first degree relatives, age wise, if it is there, and underlying symptoms of malignancy. While I'm looking for provoked or unprovoked, and you want to look for any persistent disease status there, or it is a transient risk factor. So all edema, lymphadenopathy, that's a clinical examination going on at that point of examination. Now comes the situation of laboratory testing. Laboratory testing is basically you want to look for again unprovoked causes. A complete blood count will give you a position to look for IDA, a JAK2 mutation or a sickle cell preparation. We can also look for other causes of provoked diseases. The laboratory testing will also find out whether it is APTT is deranged or not. That will tell you if it is an LA or an APLA. Imaging studies are also important in terms of the coins. Initially, we'll send these tests and 24-hour protein if there is an albumin which is low. Again, differentiating between provoked and unprovoked, transient or permanent causes. Imaging, X-ray, Doppler, and colonoscopy is to be done based upon what you are seeing. Sequential testing is what is the word used following a D-dimer, whether to do an ultrasound or a CTPA. So provocation status, confirmation, risk factor identification, primary prevention and secondary prevention is the goal of therapy here. So treat the cause, decide the choice of anticoagulation and the duration. The same gentleman, now we continuing whether to continue to do the testing or not for thrombophilia is a question. If it is a first episode of provoked VTE, we do not require testing for thrombophilia. If it is upper extremity thrombosis, do not require. Active malignancy, no. All the other causes are provoked causes of thrombophilia and therefore no need to test for thrombophilia or loss of function, deficiency of thrombosis. In terms of approach to thrombophilia of unprovoked thrombophilia, if it is suspected in a younger age group, strong family history, then it is a cause of concern where thrombophilia is entertained in our mind. It could be inherited or acquired. So these are the two things which we need to understand. If it is inherited, natural anticoagulant deficiency or a gain of function mutation. Otherwise, it is acquired. We are only dealing with antiphospholipid syndrome and rarely PNH. In inherited situation, it is about 5 to 40%. General population is about 0.2 to 10%, as I mentioned, about the prevalence of thrombophilia situation in a person. So this is the point we need to understand whether to do or not to do. The debate, should I continue to test for thrombophilic factors? You can say that, okay, there is a potential future for a thrombotic event. The alternative choice of therapy has other indications and provision of information will help us in the reproductive age. But also understand that the more knowledge we have about the defects of our body, the more worry it can cause if you do not have anything to intervene. Therefore, on one side, somebody can say if you have done a thrombophilia testing and family history can be there, and therefore do the thrombophilia testing of the entire family. All it requires, all it changes in life is the insurance premium might increase because of that. And there is no intervention except for worry in your mind that you may get a thrombosis in the future. The points against is no change in management, lack of improved survival or recurrence, even if you anticoagulate prophylactically, all of them, undue anxiety and insurance issues. So, inconclusive thrombophilias, MTHFR mutation, homocystinuria, never do testing for thrombophilia. You may consider an additional testing if the first degree relative had it and any of these were positive with regard to anticoagulant deficiency or a prothrombotic gain of function mutation. So young patients without a family history of VTE, these are the common causes where you must consider testing, and in that APLA, JAK2 and PNH testing comes the top priority with regard to thrombophilia testing, because these are three causes where we can potentially intervene if there is a possible cause. So inherited thrombophilia, to do the protein C, protein S, antithrombin, the three deficiencies and the two mutations are only helpful in a few handful of situations. Rest of them, you please look for JAK2, PNH and APLA. So not notes on specific tests, that is the APC residence of factor. You have a laboratory-based test, which all of you may know, and by a mutation testing also. Prothrombin gene mutation, it is only by mutation. Protein C, protein S, there is functional assays are available now, and there are now mutations are also available. Antiphospholipid syndrome is something which we must understand in detail a bit. APTT may not be always prolonged if you suspect. So lupus anticoagulant needs to be checked separately. Antibodies can be sent. DOACs can cause false positive LA. So essentially, anybody who's on treatment for a thrombus for any cause, I mean any of them, DOACs or heparin or warfarin, do not do LA testing at that time. Please go ahead and do glycoprotein anticardial. I made mistakes of sending the LA while the patient was on heparin or on DOAC and had difficult decision making situations once you test and comes positive. These are tests I already said, homocysteine and MTHFR mutation. There is enough evidence to say no need to test it. And earlier we used to test for factor 8 levels, homocysteine levels, and MTHFR mutations. In an unprovoked DVT, should we look for a CT scan or a PET CT scan to look for an occult cancer? This always happens in our mind. 65% we do need to do a PET CT scan, even though his X-ray is normal, ultrasound is normal, no clinical evidence to suspect a secondary malignancy there. Only if it is recurrent, then only you need to check that. So clinical settings in which thrombophilia could be considered is, this is some of the, in acute thrombosis, we must understand that protein C deficiency can be falsely there because these can be lowered. Antithrombin 3 can be reduced in acute thrombosis. In heparin therapy, lupus anticoagulant cannot be measured. While on warfarin therapy, lupus anticoagulant can cause false positives. Warfarin therapy cannot allow you to do protein. So when the patient is on, and the time frame in which the patient has got the disease and how much time has passed from the diagnosis will help you to decide whether to send what test to be sent at that particular point in time. Before protein C, protein is switched to low molecular heparin. Before sending for S and antithrombin 3, change from other deficiency can be there. Lupus anticoagulants should be always done in the absence of any anticoagulant or a clot-based test. Therefore, antiphospholipid antibody are the only thing which is unaffected, and therefore do and lupus anticoagulant while the patient is not on any therapy or only on aspirin. So these are the major players of thrombophilia, as we mentioned, deficiencies and gain of function mutations. Does it warrant to send any thrombophilia in an asymptomatic adult just because the family history is high? So few numbers in the process. Prevalence is only 10% even in thrombosis, though the cumulative in this situation can be done anytime if it is mutation. Many private labs are doing. Is one of the family members affected? Since it has no advantage with regard to prevalence, penetrance, and prophylaxis possibility, the answer is no. And the reason is because the prevalence is low and the cumulative prevalence will be less. The product of the prevalence will be low even in an asymptomatic patient. Penetrance is poor. That means even if there is a mutation, it's not necessarily that that gentleman will get a thrombosis. There is no prophylactic applicability even if somebody who has not had thrombosis has been diagnosed with thrombophilia. Therefore, it is not useful to do this as a general health checkup to see if I want to thromboprophylax you before flight or pregnancy. So we can argue saying that, okay, what if I know that this person has a mutation? If he is going in for a pregnancy or an OCP or a surgery or a long-term travel in the air flight, would it help us to decide on this? The answer is no, there is not adequate evidence. That is why I'm saying it is easy to order, difficult to interpret, because I have a few patients who will come to me saying that I did my testing because my so and so had, my brother had an acute MI or a pulmonary embolism, and I did my test and my mutation is now positive. Should I give, should I take any medication or not? There's not enough evidence to say that because you have done, you must do. Now, do not test for thrombophilia in adults with VT who have major transient risk factors. Same recommendations have come in various aspects. So it is best not to do. Now the question comes, and then come you do with that piece of knowledge is the most difficult question now we have to handle. There it is a shared decision making. We would say there is no evidence, but however, if you are very tensed and if you're taking a long air travel, just get a shot of low molecular heparin so that nothing happens to you, though it is not really required. I mean, his question will be, what if I get a thrombus and you have not given it? So that's the shared decision making, as I said, to decide whether to do or not. As we mentioned, it wouldn't change management in an provoked DVT. Therefore, no point in doing thrombophilia testing there. And unprovoked, regardless of the thrombophilia testing, if it is a high risk recurrence, you have to continue for long term, because the cumulative probability is high of recurrent thrombosis if there is if you have stopped the action. If you know, I wouldn't go through that. So in other words, you have an initial DVT. Ask the question, it is provoked, indeterminate, or it is unprovoked. If it is indeterminate and the patient is young and it is unprovoked initial DVT, we may consider doing these tests in certain situations. If it is recurrent DVT, yes, there is a definite role in doing this. If it is unprovoked splanchnic, people say add an MPN evaluation onto that. I would go to add on to say that do a good CBC, look for anisothrombocytosis or anisocytosis, look for iron deficiency, watch out for PN, watch out for PN. Doing an APLA, MPN and JAK2, or looking out for thrombophilia evidence, thrombocytosis evidence or myeloproliferation evidence and a PNH would be the key there to have the three interventions possible. I would add on to look for sickle cell disease as well. So essentially we are looking at three interventionable diseases and two long-term anticoagulation diseases of factor V laden and prothrombin gene. Arterial thrombus, if it is MI or peripheral, if it is ischemic stroke, if it is considered testing, if it is less than 40 years only. Contraception, anybody who wants to take oral contraception, should we take thrombophilia testing? The answer is no. However, If there is a previous history of thrombosis or a family history of young thrombosis or recurrent thrombosis, those are the situations it may be worthwhile uh, a testing before we start oral contraception. However, for the pregnancy, it is only history, and it may help in doing this along with the uh, history of if there is a recurrent fetal loss, you may want to rule out APLA. APLA remains a definite test to be done because that's something which you can intervene. Okay, so now take home points before we wind up. Testing strategy in an acute phase. If you were to do antibody testing for lupus anticoagulant, that is reasonable. Looking for factor V laden and gene mutations only in situations of unprovoked and you want to consider them and the disease status does not warrant indefinite therapy, it may help, but be conservative. If the patient is on anticoagulation, keep it off for 4 weeks before you do other testing. Lupus anticoagulant can give you baseline APTT, can help you whether it is positive or not. Among the treatment now, what are our choices? We have warfarin, we have low molecular heparin, unfractionated heparin, and DOACs. DOACs has come on top of the pyramid there, the better choice for everywhere except for cancer and APLA. So cancer and APLA rule out DOACs. The rest of them continue with DOACs. And when in cancer, it is low molecular heparin. And in APLA, it can be either warfarin or low molecular heparin. These are various studies to look at the DOACs versus APLA. For whatever reason, DOACs does not work in APLA. And the chances of recurrent thrombosis is high with DOAC, especially with apixaban. The studies have been done, rivaroxaban, the studies have been done. Therefore, the TRAP study, etc., has come in. It is of not much advantage. Now, the clinical equipoise exist across the world. It is not only in India and us. There are so volumes of volumes written on thrombosis, but ultimately we are asking the question, is it acute or recurrent? Is it provoked or unprovoked? If it is provoked, if it is a transient or a permanent risk factor. If it is unprovoked, what is the age? Is there any reason to consider sending for thrombophilia there or not? After that, it is about deciding what treatment to be given. Should I give low molecular heparin, unfractionated heparin, or DOACs? And therefore, the ASH has come back with this draft recommendations for thrombophilia testing. It has been there for a few years, and that apparently it has been closed by July last year itself. I could not find any publications from there. If you look through that, there are volumes written there, but however, a minor change in languages here and there, but essentially it has not deviated from what we discussed as of today. In summary, thrombophilia status can influence the patient care in a complex, often not so helpful way. If testing, wait till the dust settles is one of the adages there, because less false positives before we testing. It is helpful in risk stratification among young patients who requires estrogen therapy, as I mentioned. Maternal fetal complications testing may be helpful, especially APLA. APS testing in unprovoked VT is a good thing to do. And so MPN, watch out for MPN with at least CBCs and watch out for PNH. If it is a first provoked VTE, it would not require long-term therapy, and therefore no point in doing thrombophilia testing. As I mentioned, the provoked and anti-provoked unprovoked status will decide on the anticoagulant duration. If it is unprovoked till the risk factor exists, you must continue. If provoked, if it is unprovoked, if it is a major site thrombus, continue long term, especially PE. Recurrent thrombosis, continue long term. Anticoagulation, anti-phospholipid syndrome should be treated with warfarin over DOAC based on recent anticoagulant studies. Thank you so much for your patient hearing, and I'm sorry I could not from the groups. I mean, during my talk, but however, I'm open to the questions, and I saw one or two questions popping up in between. Over to Subha.
So there's a question in the chat box. Do you order PT21020A gene mutation as it is not seen in Indians?
So honestly speaking, I have refrained myself from doing this test unless the patient asks for it very fervently after the discussion. As I mentioned, almost it is of not much of value in clinical decision making.
It's just one question. We are open to a few more questions. If anybody wants to ask Sir a question, please type in the chat box.
Okay, since nobody is asking, I'm going to ask some questions for them to type in. In my talk, what did I say the prevalence DBT or PE was? 1 in 1,000, 1 in 10,000, 1 in a lakh, or 1 in a million? Okay, Nancy has answered it swiftly. Okay, thank you, Nancy. Okay. Which is the anticoagulant which should not be given in patients of lupus anticoagulation? DOACs, that's right. Not warfarin. Nancy, you have to give warfarin. That's a choice. Okay. Okay. If a patient has, okay, somebody has, are there any sampling and then lead to coagulated blood sample collected? Yes, of course. If your collection is not adequate, your citrate values are not adequate, your all the variables of sampling variables of PT, APTT would affect the lupus testing as well. Okay. In an acute setting, if somebody suspects lupus anticoagulant, I'll come back to you, John Cheng. In an acute setting of lupus anticoagulant suspicion, what test can you do to confirm lupus anticoagulation positivity? In other words, in acute setup, I'm suspecting LA positivity. I cannot give LA because I've started the patient. What test can I do to make the diagnosis? I'll give you choices now. Yes, that's right. So it is an antibodies can be done. So there is a question from John Cheng. Is activated protein C resistance specific for factor V laden? Are there any causes of false positivity? What I understand is that can activated protein C resistance be falsely positive in the absence of a factor V laden mutation? I would rather have any of the pathologists answer that question because I really don't know the answer. Dr. Subha, want to take that question?
Maybe Dr. Shweta ma'am?
Yes, yes. So once again, so is activated protein C resistance specific for factor V laden? Are there any causes of? So if is so basically factor 5 laden is one of the causes of activated protein C resistance, but there are chances of false positivity also. So for that, like for elaborating in that, I'll have to read a little more. I can answer it again in the this thing. I'll answer in the OTP PGP Telegram group.
Sure. So, is there any causes for APCR resistance false positivity? Let's move the mutation question side. Is there any false positively? Can you get APCR resistance? Say, if a patient is on warfarin, can you have an APCR resistance falsely positive?
Yes, we can have.
Okay.
We have, but I'm not able to recollect it completely. So I'll just take
Sure.
some time.
This is a difficult area, I must say, because it is. I mean, I say thrombosis is one area where hematologists have to use their brain maximum as compared to treating leukemias or lymphomas. Okay. Let's have some more discussion. How much time do we have, Subha?
So 10 more minutes. We can
10
discuss.
moments. I mean, just to get some discussions, I'll be happy if any one of you want to contribute and ask questions as well. Okay, so we talked about patient in an acute setup, upper limb catheter-induced thrombosis. Or patient has upper limb thrombosis, not catheter-related thrombosis. What predictive score would you use in a patient of upper limb thrombosis? Okay, maybe you didn't. I mean, I just said it in passing. It is constant score. So basically, we have well score for deep vein thrombosis, limb, or limb venous thrombosis. When it is pulmonary embolism, we have the Wells score to be diagnosed. Okay, S. Sharma is mentioned, sir, is prolonged B12 deficiency can lead to hypercoagulable state. That was the thought process earlier, and in fact, that was my thesis as well. The homocysteine levels are high in MI patients. They had a concomitant B12 deficiency. Although that has been mentioned, but that is not the diagnosis wise we have not been able to prove that B12 deficiency definitely causes hypercoagulable state, and therefore homocysteine is out of the market of testing now. Yeah, factor 5 laden is a gain of function mutation, and that can cause APC resistance, but I don't know whether any other factor mutations can lead to APC resistance. We also talked about women with recurrent abortions. That is one of the difficult choices which we often have. Apart from ruling out chromosomal abnormalities, we must ask for history of thrombosis, and often we look out for this and ask for the APLA testing there. So APLA testing PNH, and most of the tests do not talk about PNH, and I want you to be cognizant that look at that MCV. Look at that CBC is a very important. When you come with DVT or a thrombus, look at the CBC, hemoglobin low or high. High, very high, TLC on the higher side, platelets on the higher side, or anisothrombocytosis. Think through myeloproliferation. If the HB is low, look at the MCV. MCV low, think through PNH. If there is DCT positivity and thrombosis, LA is very highly possible. So those are the three acquired causes I would say you must watch out for. And sickle cell, of course, it is self-evident if they come with sickle cell. So more than factor 5 laden, more than PT thrombosis, yes, this is what is important. And also understand the false low protein C and protein S and antithrombin 3 in an acute thrombus. I think I'll leave there and over to Subha and Shweta. Yeah.
So there are no more questions.
Yeah. So I've got the answer for acquired causes of activated protein C resistance. So there are many other causes, including antiphospholipid antibodies, increased level of factor VIII, then pregnancy, estrogen therapy, and OCPs. These factors also may cause activated protein C resistance. So basically, most common causes, yes, of course, activated, but otherwise these are acquired causes, so they may lead to false positive results.
So therefore, we went from functional affiliating testing, that is APCR, and because there is inherent false positivity, right? That's what you're trying to say.
Right. Yes, sir. Yes, sir.
Okay.
Okay, if there are no more questions, Joseph, so thank you so much. Thanks for the wonderful talk. And